afternoon, I'm Roberta Carossi from Genova, Italy, and I'm going to present you a clinical case of DADA2 patient that, in our opinion, enlarged the clinical spectrum of the disease. We are going to describe the clinical phenotype of a child with DADA2 in which the diagnosis was made thanks to a next generation sequencing panel for auto-inflammatory disease and immunodeficiency. The patient is a Vietnamese girl that was adopted at the age of 3 months that started to have an inflammatory phenotype at the age of 6 years. Of note, the patient in past history had recurrent infection of upper airways and she had an hepatitis due to CMV infection, and after vaccination she had measles. The patient at the age of 6 had this persistent fever associated to arthralgia and elevation of acute phase reactants, and soon after the beginning of the symptoms she displayed clinical and laboratory findings that were suggestive for an hemophagocytic lymphocytosis that was confirmed by bone marrow aspiration. At that time, the patient was treated with high doses of steroids, EV, with control of the clinical picture, and then was sent to our attention. When we saw her for the first time, she was receiving high doses of steroids, so we progressively decreased the dosage, and again she had the occurrence of fever. Therefore, we tried to treat her with anakinra, an interleukin-1 inhibitor, without clinical response. At that time, the immunological studies just revealed a reduction of NK cells and a slight reduction of immunoglobulins. The only findings in the laboratory test for infection that was remarkable was the presence of parvovirus DNA at the search with the PCR. So at the time, we tried to treat her with high doses of immunoglobulins in order to try to reduce the steroidal treatment. And with that approach, we obtain a good control of the clinical phenotype because since fever disappeared and acute phase reactant reduced, and we could progressively reduce the steroidal treatment up to discontinuation. Due to persistent well-being at the age of 9, we tried to switch the treatment with immunoglobulins from anti-inflammatory to substitutive, but we had the reoccurrence of the clinical picture. She had a zoster reactivation, as you can see in the picture, and following that, it was of course treated with EV aciclovir, she again started to have the inflammatory phenotype with a fever, and soon after she again had an episode of HLH, at that time with a neurological involvement with the lethargy, irritability, and electroencephalogram consistent with encephalitis. And therefore, she was again treated with a doses of steroids plus immunoglobulin with good response. I have to say that an MRI was performed at the time of HLH that was negative. By following one, detected the presence of a small gliotic area. In the following years, the patient again was treated with immunoglobulins with good control of the clinical picture. We performed for the immunological study that was did not reveal any other important findings. She continued to have low levels of NK, but the peripheral levels as well as the activity were normal, and the tests for ABS were negative. Given the clinical picture, we, thanks to the help of a colleague in Vienna, we could perform a large NGS panel that revealed the presence of a new mutation in DADA2 gene that is not known by now, is not reported in the literature. The frequency is not known, and it's reported as probably damaging by Varsom. But in order to confirm the pathogenicity of the mutation, we performed the enzymatic activity in our patient with by high performance liquid chromatography in the monocyte of the patient that was cultured with adenosine and another one inhibitor, and you can see that is an important the absence of the adenosine metabolite. So in conclusion, this clinical case is enlarges the clinical spectrum of DADA2, revealing the presence of severe inflammation together with symptom and signs of HLH, and in this clinical case emphasize the importance of NGS paneling in patients with a phenotype that is not unclear, finally, the use of high doses of immunoglobulins can be of help in in patients with DADA2, also for the control of the inflammatory phenotype. Thank you.